Good afternoon, and thank you for joining the Duke Initiative for Science and Society for the next installment of our Coronavirus Conversation Series, co-hosted today with the Samuel Dubois Cook Center on Social Equity at Duke University, the Duke Center on Law, Race, and Politics, and the Duke Center for Science and Justice. My name is Sarah Rispin-Sedlak, and I'm a senior fellow at Science and Society and the faculty lead for our Coronavirus Conversation Series. In a moment, I'll introduce the speakers and moderator for today's event, which will examine systemic and individual racial bias in the healthcare system and how it may be contributing to disparate outcomes from COVID-19 treatment. And now please allow me to introduce our panelists. Kiara Bridges is a professor of law at the University of California at Berkeley, where she teaches on critical race theory and race-based disadvantages. She's detailed the history of implicit biases and racial disparities in healthcare in her research and has written 3 books, including Reproducing Race, an ethnography of pregnancy as a site of racialization. She's been interviewed extensively in the press since this pandemic has begun about racial bias in healthcare decisions around COVID-19. Dr. Daniela Lamas is a pulmonary and critical care physician at Brigham and Women's Hospital, where she has been treating COVID patients since this spring. She has written about her experiences as a physician for the New York Times, including a discussion of how the hospitals to which patients have access affect their quality of care, and published an article in The Lancet examining disparities in recovery from critical illness due to COVID-19. Finally, Sylvia Perry is an assistant professor at Northwestern University, where she works within the Institute for Policy Research and researches factors into how individuals feel a sense of belonging in healthcare settings. She studied biases held by American healthcare workers, including regarding COVID-19, and how white families discuss racial inequalities with their children. Finally, our moderator today is our very own Thomas Williams, who's the director of our joint JD-MA program in Law and Science Policy. He sits both within Duke Law School and the Duke Initiative for Science and Society, and has personally researched issues surrounding racial bias in healthcare for some years now. With that, I'll yield the floor to Thomas to begin the conversation. Thank you.
Thank you, Sarah, for the introduction. Thank you to our panelists, and of course, thank you to the audience who has joined us on a Thursday afternoon when I'm sure they have plenty of work to do. I'm really excited about the conversation that we're about to have, in part because I think it's really important that we start to strip back the pieces of the conversation that are missing. Health disparities have loomed large in public health and social, legal, and medical discourse for decades. And while we recognize that for many of you, this may be a newly relevant space, you should know that as far back as the early 1980s, the federal government under the Reagan administration acknowledged and decided to take specific action with respect to health disparities on a national level. And you should also know that that response was chronologically very close to the public outrage that came from the Tuskegee trials. Margaret Heckler was the Surgeon General who created what is the OMP, the Office of Minority Programs. You'll now know it within NIH as the National Institute of Minority Health and Health Disparities. She died in 2018, but clearly her work lives on. First, I just want to give you a brief definition of health disparities so that we're all thinking about the same things as we begin to talk about bias and outcomes. Health disparity refers to a higher burden of illness, injury, disability, or mortality experienced by one group relative to another. A healthcare disparity typically refers to differences between groups in health insurance coverage, access, and use of care. And that comes from the Kaiser Family Foundation. We're going to be talking about issues that touch both. You should note that it's only been 40 years that we've been thinking about this. So on one hand, it's not a whole lot of time, but also we might think that we would have perhaps moved greater mountains in that period for Black and Brown people. For many of us, it may not be surprising that this is the reality of the outcomes of the COVID-19 pandemic, but it is still shocking. This is personal for many of the panelists, for myself, and for many of the people you engage in conversation with around health disparity. And we hope, again, that this conversation will help us to peel back some layers of the onion that is disparities and that is bias from that flat conversation that we sometimes seem to have. We're seeing ongoing violation of Black and brown bodies right now, and really obtuse, violent ways. That includes the murder of Breonna Taylor in Louisville and the maiming of Jacob Blake in Kenosha. And the conversation we're having is arguably speaking to a more insidious violence, and one that impacts Black and brown bodies perhaps even far more than those very aggressive, intense incidents of violence. You can't escape health disparity through education, and you can't escape it through wealth. At the same time, economic factors weigh heavily in the conversations that we have focused on disparity. And we've seen that in the labeling of who and who is not essential, their ability to isolate, and the expectations that they go to work. According to a piece published in the Wall Street Journal last week, minorities in the United States are dying at a higher rate within lower age-related demographics. This is one small piece of the disparities that we see with respect to COVID-19. So for individuals who die of COVID under 55, only 3% of those people are white, whereas 11% are Black, 18% are Hispanic, 8% are Asian American, and a whopping 24% are Native American. Nationally, there have been almost 6 million infections from coronavirus. In North Carolina, obviously, that number is far smaller. But the trend of health disparities is seen here as well. According to a recent CDC report, of 18 counties in our state identified as COVID hotspots, 18 showed Hispanic and Latinx communities as carrying a disproportionate number of those infections. Nationally, there have been over 180,000 deaths. In North Carolina, that's closer to 3,000, just under. And we see that disproportionality in all of these numbers. But what we don't see when we talk about the numbers are things like, what is recovery? Do we have an objective measure? What does it mean to be in the space in between, and what does it mean for families and communities? What are the experiential components of the numbers we see and the stories that connect to the data points? Are there things that come before? Are there things that lie between? Are there things we see later between infection, death, and or recovery? What other data do we need to understand what's happening? What other pieces are missing when we only focus on outcomes? With that, I will turn over the floor first to Professor Kiara Bridges.
All right, thank you so much. It's such an honor to be a part of today's conversation, and I just want to start the conversation by complicating things a little bit. So when a lot of people in institutions, ranging from the media to medical schools and residency programs, when a lot of these institutions discuss racial disparities in health, they tend to focus on implicit bias. And with regard to medical education specifically, when programs address racial disparities in health, they either explain it in one of two ways. The first way is to explain them in terms of race-specific genetic variations, which is so problematic that I don't have time to get into it today. I will just say that race-specific genetic variations are a figment of our collective imaginations. Or when medical schools address racial disparities in health, they tend to talk about it in terms of implicit bias. And the woke medical schools might even give their students an implicit association test so that students know the extent of the implicit biases that they have. And so then programs tell their students to go out there and be mindful about how their documented implicit biases may influence the healthcare that they give. Then that is incredibly laudable. But the issue, my complication that I want to offer is that racial disparities in health cannot be explained entirely in terms of implicit biases. The general tendency has been to stop the conversation when we acknowledge the existence of implicit bias. The fact is that providers have implicit biases. The fact that providers have implicit biases is an incomplete explanation of racial disparities in health, which is to say that implicit biases have to be put in conversation with institutional and structural racism. So there is a compelling argument to be made, and I've made it, that the problem is not that individuals have implicit biases. Instead, the problem is that we have constructed a society wherein people of color are at the bottom of most measures of social well-being. So people of color more frequently bear the burdens of poverty than white people. People of color are more incarcerated than white people. People of color are confined in immigrant detention centers more often than white people. People of color rely on the social safety net more often than white people. People of color are unemployed more frequently than white people. People of color die violent deaths more frequently than white people. And it is doubtful that implicit biases alone can explain these disturbing inequalities. More likely, the reverse is true. These inequalities explain implicit biases. And so it is for that reason that progressive race scholars have argued that the best approach to dealing with implicit bias is through a sustained process of social change that results in the elimination of racial inequality. If people of color were not at the bottom of social hierarchies, providers likely will not have negative implicit biases about them. But again, perhaps the most important intervention is to put implicit bias into conversation with structural racism. If we paid attention to structural racism, we would see a lot of things. We would see that individuals who have implicit biases, as well as individuals without implicit biases, are practicing medicine within a two-tiered healthcare system. And it's a system that allows for the privately insured to access healthcare that is simply better than the publicly insured, not to mention the uninsured. If we paid attention to structural racism, we would see that the people of color live in more polluted neighborhoods. And as a result, they are more likely to be exposed to toxins that compromise their health. And please note, as Thomas mentioned, that people of color's disproportionate exposure to environmental hazards is not just a function of the disproportionate poverty that people of color bear. Rather, it is a function of people of color's racial disadvantage. Studies have shown that if you compared middle-class communities of color to low-income white communities and look at which community is more likely to have a hazardous waste facility sited there, the middle-class community of color will have a greater chance of being targeted for such a facility as compared to the white community. Robert Bullard, who is, I would say, the grandfather of the environmental justice movement, he observes a similar phenomenon when it comes to air quality. He observed that if you look at Black households with incomes of $50,000 to $60,000, they live in neighborhoods that are more polluted on average than neighborhoods of white households with incomes with less than $10,000, right? So it's not simply a function of poverty, it's a function of racism. And I should note, and I'm going to stop soon, that the range of environmental hazards that people of color encounter is truly vast, almost comprehensive. We're talking about lead exposure. We're talking about living close to hazardous sites and incinerators and polluting factories and brownfields. We're talking about the water, right? And also, people of color are more likely to be employed in jobs that expose them to toxins over the course of the day. So farm workers, nail technicians, sanitation workers, right? These are all the jobs that people of color disproportionately have that nevertheless compromise their health. So again, we would see a lot of things if we paid attention to structural racism, and our conversations about implicit bias can't stop there. They have to be put in conversation again with these things that we already know about structural racism. And I'll stop there. Thanks.
Thank you, Professor Bridges. Lots of good fodder there for conversation. Next, we'll move to Dr. Daniela Lamas.
So, I mean, that's fascinating, and I think is like though we did not plan this order, like the perfect kind of lens to put to what I'm going to try to give, which is essentially an overview of what one hospital, which is similar to sort of all hospitals through the country, saw in the pandemic, and sort of what we're thinking about moving forward in terms of outcomes. And so I'll just begin by giving you a little overview. You know, it's late April, early May, which was the time of the surge here in Boston, where I live, and walk through the unit. This is the COVID intensive care unit, so it's a cardiac surgical unit that was revamped. And you walk through, there's full of patients. There's a patient in each room. The doors to the rooms are closed. All the patients are intubated, many lying on their chests, so you don't even see their faces. there's a small poster outside each room that'll give you the bullets of each person's story. And so I'll just give you a sampling of a random day, which actually had written down. So I walk through, and on my left in the beginning, there's a 45-year-old man from Bangladesh who has 3 children. One of them was the first person in his family to get sick. He works in a discount liquor store and was worried about stopping working when he started to get sick. There's a 45-year-old gardener from El Salvador, a 43-year-old white food delivery man, a 43-year-old Black man with developmental delay and due to a chromosomal abnormality who lived in a group home, a 52-year-old Black man from Haiti who was a cab driver here in Boston, a 68-year-old man from the Dominican Republic who had cancer and was in the hospital for cancer treatment when he got sick, 43-year-old man from Cambodia who wasn't working at the time he got sick, lived with sort of multiple generations in a small apartment outside of Boston, a 52-year-old woman who worked in the cafeteria at our hospital, and a few older patients from a nursing home near the hospital. So that's a microcosm of the population that this disease impacted. These were essential workers, people who lived in multi-generational homes, group settings where inadequate access to personal protective equipment and testing left them all in jeopardy. These were communities that had poor access to healthcare, some of them, and all of these patients, or many, not all, but many of these patients were disproportionately from BIPOC communities. And why was this? And I'll tell you, at the beginning of COVID, it wasn't this way. So we started seeing patients in mid-March who were largely from wealthier communities. These were patients who got sick because they had enjoyed recent international travel. We had a couple who likely got sick on some nice sort of late winter ski vacations. But as we found out about COVID, these were the people who could afford then to isolate, to quarantine in their homes, leaving the disease that they brought to us run rampant among more vulnerable communities. And how did it run rampant? It's not because of race-specific genetic variation, which is important, I think, to make explicit, because even among people who were relatively sort of intelligent people, even early days in the hospital, that was a question. Why is this? It was instead because of exactly what Professor Bridges was telling us, that we are living in a society where people of color are more likely to be essential workers, are more likely to live in these areas where they're more likely to get sick. And we know, as a result, all of the numbers that Thomas told us, that the fact that ultimately Black people were 3.6 times more likely to die of this disease than whites, and Latinx populations 2.5 times more likely. So we know all of this, right? So we know that these are the outcomes. We know that the outcomes that we talk about, death, is what we sort of cite most. But now when we think what to do with this, I mean, to the point that Carrie, you were making, like, we say this is true. Okay, we know this, like, it's sort of like acknowledging implicit bias, but then what do we do? And that's a big question, and definitely not one that I am equipped to answer in these 2 minutes, or even really if you gave me 200 minutes, I wouldn't be equipped to answer it. But but I think one sort of way to start is saying, as we're talking here about outcomes, how do we tell this story? And what kind of information do we need to accurately tell this story? And so some ideas about how we tell this story moving forward. I mean, I think our story can't stop at death. It can't stop at those numbers. Our story has to take into account what happens to everybody after the hospital, who is able to get care for the mental health crises that will inevitably ensue as a result of this, who is able to get back to work, what happens to people when they don't get back to work, who is able to have these sort of odd symptoms of COVID that need a cardiologist, an infectious disease specialist, who's a neurologist, who is able to have access to that, who is able to feel trust after this in order to get a vaccine, if this is a vaccine that we should all get, who gets that and who doesn't. And I think, that is going to be part of the human toll of this virus that we see, and understanding that arc is, I think, something that is essential for us to understand as we try to sort of look to what happened and try to make change. So, survival is just the start, obviously, when we talk about outcomes. We're going to have to work to determine and measure the outcomes that matter to people if we hope to offer this full narrative and ultimately make change. I guess I want to say finally that, we know that COVID has laid bare these inequities in our system. It's obviously true, but I think there's something else that this virus has revealed, and that's the extent to which we're all interconnected. None of us exists as an island, and what I do impacts you across the country and vice versa. And so there will be a day when we're no longer in the midst of this. And I hope that one outcome we can take from it is this understanding of interconnectedness, and that perhaps that which was a scary thing in COVID, that's the nature of super spreading events, but it's also something that is true and that's sort of beautiful, and that isn't just about this virus. And hopefully we can use that in some way to think about moving us forward.
Wonderful. Thank you, Dr. Lamas. Last but certainly not least, I will take the least crown. You're going to hear from Dr. Sylvia Perry. Thanks so much.
Thank you so much. Both Kiara and Daniela had some really wonderful points that I think are good jumping off points for me. And for me, I am really interested in implicit bias, but I'm also interested in structural racism, and in particular, how things like the training that happens within medical school might shape the trainees' attitudes, how they interact with patients, and also people's awareness about their own personal biases might shape the way that they interact with patients. And so just thinking about what Professor Bridges said about structural racism, we know that in situations in which attending physicians are exhibiting more prejudice, more discrimination, more racism toward Black patients, that the trainees themselves go on to display more bias at the end of medical school. And this happens even in institutions where they are receiving implicit bias training. And so we consider this to be something called an informal curriculum, right? So what are we seeing around us and what's being signaled around us when we go to make judgments and decisions about patients? And how is that information from the top down trickling down and influencing the decisions that we make about people? So I like to talk about some of my personal stories because I am a person who studies healthcare provider bias, implicit negative attitudes, right? But I'm also a Black woman. And I think that when we think about these situations, a lot of times people are talking about the various factors, right, that might explain why Black people are experiencing health disparities. But it's also important to think about intersectionality as well. When I've gone to, so when I was pregnant and I went to the hospital and I had my own experiences and I have all this knowledge about bias and how it plays out, it was really stressful for me to have all of that knowledge, to have a PhD, and to still experience those things myself, right? So to have the medical professional make assumptions about my diet, my health, my cultural practices and norms based on what she thought to be obvious basic information about what it is that Black Americans do, right? And those sorts of assumptions can play out on both sides, in that if you make assumptions about someone's cultural practices and their health and so forth, it can be the case that somebody who you assume to be more healthy, right, that you sort of under predict or estimate their health, or if you assume that someone is not going to adhere to what you say or come back, if you provide them with some suggestions, that also is going to have negative implications for them. And so, what happened for me after those kinds of encounters, and what often happens with Black patients, is that it reduced my level of trust, right, for that provider. And it made me experience a lot of negative emotion. It made me feel a bit of discomfort about myself. And so how do those sorts of situations play out long term, right? So if I'm a Black person and I go visit a healthcare provider and there's something about their nonverbal behavior, right? So maybe they're saying one thing, right? But maybe their actions, their behavior, whether they're making eye contact, whether they're asking me personal questions about me, to be able to hear me and see me as an individual, as opposed to this overarching stereotype, right? How does that shape my perception of the situation? And we know that when Black patients have these encounters with healthcare providers who say, I don't have any biases, and yet do show some implicit negative attitudes, right? So they lack this awareness, that when these people walk away, they feel like the encounter was less warm, right? That they trust this person less. And of course, that will then impact their willingness to come back, right? And so it's this cycle where people have this stereotype that Black people might not adhere, they might not return, but they don't recognize that there are things that they may be doing, whether they are unintentional or not, that are influencing how those individuals are responding as well. And so these are some pieces that have been really important to me. And when thinking about implicit bias, right, and what Professor Bridges was saying, I do think it's important to not just focus on, for example, a score on the IET, right? So I think of that as a tool to introduce people to what's in the air, what's going on at a societal level that's influencing our associations, right? But then what happens after that on a personal level? So can we be humble? Can we gain awareness and say, hey, I probably have some biases myself, and this might be impacting my decisions? Can we then reflect on something that's counter to what our assumptions are when we're engaging in an interaction with a person from a certain group? And how can this awareness shape our ability to hold empathy toward this person, right? Because we know that racial discordance, right? So when there's not racial concordance, when it's a white healthcare provider and a Black patient, right? There can be disconnects in terms of people really hearing someone and empathy. So I think that this awareness piece is extremely important. Motivation, right? So how can we stay motivated to change our behavior and to be humble and to assume that we are biased, right? So a lot of medical professionals might say, I went into this because I want to help people. You know, I find it hard to believe that I am engaging in these kinds of behaviors. But I think it's really important for people to think about how what's in the air, what we're constantly hearing, and the stereotypes we're hearing, right, might still be influencing their judgments and decisions and leading them to not provide quality care. And in the long term, leading the people who they see to not trust them and to not want to come back and to not want to interact with them.
Thank you so much, Dr. Perry. So we have a lot of questions queued up. I have my, I think, one of my favorite questions. Can you talk about, and I think this is really critical in terms of framing, the idea of talking about disparities with the general public without at the same time, right, creating this space in which racial difference becomes more pronounced and it feeds the kind of the heuristics or the narratives that folks have already built. Can you say, each of you from your perspective, a little bit about that?
I'll start because I think I did the biggest eye roll when I heard that question. So just judging on eye roll alone, I should start. No, so it is so incredibly, it's hard to, so the reality is that this stuff is complex and it's nuanced and it's hard, it takes a level of complexity to sort of understand what's happening. And so it's hard to translate the things that, we know to be true to folks who might not be steeped in the same kind of literatures that we're steeped in, folks who might not, let me just be precise, folks who might accept the myth of biological race, right? Like that Black, white, Asian, Indigenous, Latinx refer to sort of genetically homogenous groupings of individuals, right? And so when you start saying, oh my gosh, Black women are dying at 3 to 4 times the rate of white women when it comes to pregnancy-related deaths, and oh my gosh, Black folks are dying at 2 times to 3 times the rate of white folks from COVID-19. When you hear those numbers and you have this underlying assumption of, okay, biological race, then you start explaining it in terms of, so Black people just have this gene that predisposes them to death. Or, Latinx people, Native, Indigenous folks, they're dying because something about their genes, their genome. I think it's so important to reiterate time and time again that race is a social construction, but it's real and it has consequences, right? And so it is not a biological category that has political effects, rather it is a political category that has biological effects. And maybe it's possible to come up with a meme or some sort of, 280 characters, is that what we're doing now? But it's so important to reaffirm time and time and again that we have made these categories, and we've made them have meaning, material meaning, and as much as some folks are dying and having, you know, a lesser quality of life and, you know, more morbidities and et cetera than others because of this thing that we have created. So,
Great, thank you. And that is your challenge as a meme audience. Show us your memes. Anyone else?
Can I speak to that?
Absolutely.
Yeah. So I think for me, what I think about when I think about these disparities and then not essentializing it, right? So not saying, like you're saying, Kiara, is it's something that's in the makeup of Blackness, you know, is when we think about things like socioeconomic status or other factors that are sort of predictive of these health outcomes, and we hold those things constant, there's still racism on top of that, right? And this thing gets under the skin. It gets under the skin and it kills. And so, you know, I've given the, you know, Dr. Dale Su talks about microaggressions and how it's death by 1,000 cuts, right? So daily experiences, daily slights, right, that lead you to have these physiological, you know, responses that impact your health and well-being over the long run. So irrespective of your standing within society, there's that racism on top of it, which has huge implications. And so, you know, when we're talking about the makeup of something, right, like you were saying, Kiara, it's really about that social construction being tied to treatment, right, as opposed to that category in and of itself. And I think if you even look across multiple different societies, right, and which group is that group who's treated the most poorly and who's assumed to be at the bottom, right? And you look at things like education and imprisonment rates and health, shockingly, right? You see the strong correlation between what's going on in the United States with those groups and what's going on in these other countries. And so I do think it's really complex, and it's important for us to talk about these disparities and what leads to this, but to never leave that piece of the puzzle of racism out. And I just want to say really quickly, because Daniela, I want to give you some time as well. I think that one thing that was really frustrating for me when this whole conversation started is the level of shock that people seem to have, right? Like, oh, wow, like we're understanding now that these things must be explaining these differences, and oh, wow, racial bias in healthcare. And I think for a lot of researchers who have been studying these questions for a very long time, it was kind of like, well, yeah, you know, what have we been doing with our careers? We've been trying to tell you this for a really long time. And so, you know,
Actually,
huh?
are you new here?
Right, right. And so I also think that, you know, that just speaks to this idea of, hey, there's this thing in the air. Let's not forget about it. It's been here for a long time.
Thank you.
I guess I'll only say, like, you know, as a doctor, somebody's in the hospital, it also gives us, you know, thinking that there is some sort of race-based genetic reason for what we see. It allows us to disavow, us as doctors, us as a society, really, to disavow responsibility, and that's a danger. And B, you know, it's not just in COVID, right? So we've been thinking, you know, I went to med school, never noticed this, but there, sort of race is built into many of our clinical algorithms. So from the beginning of us learning to be doctors, we have sort of baked into the things that we memorize this little fact, which is not fact, but is purported to be fact, that there is this black or white non-white or black non-black difference in how we estimate the risk of somebody having a cardiac event when they're undergoing surgery, how we determine normal kidney function, how we determine normal pulmonary function. These are all, I mean, we have race in this algorithm. Like, you know, you go to MD Calc and it says black or not, and you click it or not. And that's in there. And this is, oh, there's a difference. You look into how these algorithms were, you know, came to be. there's no real basis for this. Like there is no scientific basis. And in fact, it's dangerous because in some of these algorithms, sort of the way it leads you will lead you to make inaccurate assumptions, to say, oh, there's less of a risk of a cardiac event after surgery or more, et cetera. And so there's now, a move to moving away from this, et cetera. But just, but you see it reproduced in all these different ways, and that matters. So yeah, I think that there's a danger in the hospital now for COVID to play out in the same way, for us to say, oh, this is a Black patient coming in, maybe they have a higher risk of having COVID. Is that true? No, not. You see somebody in the street, it's a higher risk of COVID? No, I mean, that's not the takeaway. So anyway.
Thanks. Daniela, just while we're with you, do you know if med students move through bias training and if that's increasing to the extent that it has any impact?
Increasing to the extent it has any impact, that I don't know. Increasing, yeah. I didn't have that in med school. I was in med school from 2004 to 2008. I don't remember. I wasn't really focused on a lot of med school, because med school is really unpleasant, but I don't remember having bias training. At least it wasn't one of the days that I came to school. But I do believe that does exist. But how does that, how does that really happen? I'm going to send, there's a chat question about a reference to algorithms. I'll send a New England Journal article about that out on the chat.
I can speak to that really quickly. So in the longitudinal work we've been doing we looked at 50 medical schools, so several thousand medical students, and there is a significant increase in implicit bias training. Even as it relates to people getting into medical school, there's more conversation around health disparities, but the training, right, when you accounted for things like them observing, attending physicians, engaging in discrimination, the training no longer explained, attitudes down the line. So again, if there's this disconnect between the formal stuff that's happening and the informal stuff that's happening in the background, it doesn't matter as much. So it turns out what's happening within the organization matters more than just this training.
So we got this interesting question that I think is both appropriate, but that I want to push back on a little bit, which was, can we get back to COVID? And I think what we're doing is actually, right, getting back to the roots of thinking about how COVID and outcomes is a far deeper, more historically entrenched conversation. Can you say something about what the conversation around COVID should sound like, vis-a-vis kind of wanting to look at data points that are directly related, and how we can ask people to kind of think broadly and across kind of structures and areas of study to incorporate that?
I'll start by saying, back to COVID, part of what explains higher mortality rates from COVID-19 among non-white groups is what Dr. Lamas was explaining about. We are essential workers, so we can't shelter in place. We can't quarantine. We actually have to go out and clean the hospitals and clean and, drive the buses. And so, but another important piece of the explanation behind higher rates of mortality among non-white groups is underlying conditions. So we already had higher rates of hypertension prior to COVID. We already had higher rates of diabetes. We already had higher rates of lung disease. We already had higher rates of these comorbidities that make infection with coronavirus much more likely to be deadly. So back to COVID means, this is an opportunity for more people to become aware of something that we already knew, which is that people of color are suffering the effects of structural racism. And the coronavirus has just made structural racism that much more deadly. And so if we're interested in using COVID-19 as an opportunity to undo some of what we have done. I mean, this is such a profound opportunity to undo, like, you know, the dearth of a competent public health system, right? The tying of insurance to employment, such that when you lose your job because of COVID-19, now you're uninsured, right? So we have an opportunity to look at these sort of systemic issues, and we have an opportunity to say, okay, why are people of color just like, you know, higher rates of hypertension and diabetes and heart disease and lung disease? Why is that? And so it's bigger. It's a huge problem. We have to look at residential segregation. We have to look at voting rights. Right? Because we have to look at who's on zoning boards, who's zoning these neighborhoods for hazardous facilities and incinerators, and are not zoning these neighborhoods for green spaces. We have to look at environmental regulation. So back to COVID for me means to look at the huge structural issues that have produced increased mortality among non-white groups.
Wonderful. Anybody else want to chime in on that front?
You know, I guess I'll say, like, my view of COVID at the outset has been relatively sort of what's in front of me, you know, like I took care of a lot of patients who had COVID. And so on the small picture, but which could be reproduced more broadly, it's also saying we took care of all of these patients. How can we help them re-enter their lives as well as they can? How can we make sure that people who might not have access to mental health screening get it? You know, so for us, for our hospital, it's a clinic for everybody who has had a diagnosis of COVID to come to see a pulmonary doctor, maybe an infectious disease doctor, a social worker, a psychiatrist. That's lucky that we have, you know, our hospital is putting funding to do that for people even whose insurance we don't generally take, because we saw these patients in our hospital as these, you know, super sick ICU transfers, and we have a responsibility to them afterwards. But, you know, what can we do in our system that actually allows that more broadly is also, you know, a big question. But clearly that's you know, that's not proactive. I mean, this is responding to this crisis, which we need to do, but also to all the points you're making. I mean, you know, who has asthma that thus made the lung disease worse? You know, so all of these questions, I think we all feel like, oh, it's all illuminated, but there's a huge risk to just saying, like, yes, I recognize this. This is so unfair. Let's just hope that we have a vaccine soon, and not saying, like, all right, you know, all of these issues will continue even when there's no pandemic. And so I think that hopefully is empowering instead of overwhelming. Maybe it's both.
And I think, right, the underlying concept of it, it's been with us forever, whether or not you saw it, right? This idea that I'm shocked but never surprised is kind of what seems to be flowing through all of this, that it's everywhere you look if you decide to. Dr. Perry, did you want to add anything, or?
No, those were both great points. I don't have anything to add.
Okay. So I have two questions. We have about 10 minutes left. So the big one for me is so we've gathered together, right, to talk about outcomes. And outcomes for most people has very clear significance in terms of data points, right, kind of tangible evidence. What is it that we should be measuring? What would help us kind of understand this better? Fit it into narratives that make sense. I think there are a lot of pieces to this. It's about how the media discusses things, how they kind of do the peeling back of the onion to force us to see more. But if it was up to you, what are kind of 2 or 3 data points outside of the ones that exist that you want to see that help to explain outcomes?
I mean, for me, from like the sort of how am I going to care for people moving forward perspective, I mean, I'm interested, you know, so I've been interested in like ICU outcomes aside from mortality pre-COVID as well. And I'm interested in return to work. I'm interested in mental health outcomes. And I'm interested, I mean, like the sort of health related quality of life stuff is like very imperfect. You know, I'd be interested in some sort of general question of to what extent people are able to feel like themselves or get back to the things that they love doing. I worry that there will be disparities in those outcomes as well. And so I'd be interested in that.
Dr. Lamas, can I ask you a quick follow-up question?
Mm-hmm.
When we see the word recovery, is that clear to viral load? The questions you ask about kind of return to activity and kind of my clinical ethicist hat are kinds of the questions we ask folks around kind of end of life and making decisions. Can you say a little bit about exactly what the science of recovery, when we see that on the Johns Hopkins dashboard, means?
Yeah. I mean, we're not necessarily even tracking like clear to viral load. So I really think this is like somebody who had COVID and is non-dead, is recovered. It doesn't mean that they're back to doing the things they like to do. It doesn't mean that they can like make a sandwich or play with their kids or do whatever, go to work, write a story, focus, not wake up with nightmares in the middle of the night. It doesn't mean any of those things. And so it's limited.
Thank you. Dr. Bridges, Dr. Perry, Professor Bridges, excuse me.
So I think that when I think about this, especially like you're saying, Dr. Lamas, if we're focusing on what's happening after, right? And also what leads people to seek out care in the first place. I'm interested in the quality of people's experiences, the quality of the care, follow-up about their experiences, and whether they thought they got the services that they needed, whether they felt like someone listened to them, and how those things might be associated with some of the things that Dr. Lamas is talking about, right? Because I think that there probably is a gap in some ways of people's willingness to even go get tested if they've had negative experiences in the past. And then after they experience this, maybe they test positive or maybe they are sick, their willingness to follow up with people based on the experiences they had while they were in the hospital, while they were encountering a healthcare provider. And so I think that piece regarding the quality of care that was provided is really important in people's experiences during those interactions.
And when you say quality, you don't mean like, did the stitches look okay? You mean kind of what was the experiential kind of engagement with the person? Did you feel like you were treated with dignity?
That's it. Okay. That's exactly right.
Yeah. And I'll just also say that Dr. Perry and I, in leading up to this conversation, talked a lot about, similar to the birth experience, being in spaces and really questioning whether the medical care you were experiencing is the same as other folks. And so that I just want to give voice to that being real for many, many people of color. Dr. Bridges, what do you want to measure? Professor Bridges.
Doctor or professor works for me.
Doctor, it's technically.
Yeah, so good. No, I think I would just be repeating what Dr. Lamas and Perry have already said. So I would be interested in both of those things. Yeah.
Wonderful.
And since I'm unmuted, but I would also be interested in seeing what has changed down the road. Like I would love to do a postmortem, terrible word for this, but a postmortem like 20 years from now to see whether, the things that we know are compromising health and producing higher mortality rates among people of color, if anything has changed in 20 years. So I'm talking about residential segregation. I'm talking about, environmental injustices. I'm talking about voting rights, all the tying of healthcare or health insurance to employment. I would be interested in seeing whether we learned anything, in terms of,
This is perfect. You queued me right up for my question, which goes back to my favorite thing. But I also just want to say that the things you were just talking about are what we often kind of term social determinants of health, right? And which folds in the idea of stress, which is the new hypothesis, especially when we think about African-American women, specifically women of color, and the differentials in terms of outcomes in birth. We just saw the new article around the death rates of babies in mismatched provider settings, which we can share with folks, but is deeply distressing. And we know that African-Americans, the telomeres, some folks wanted me to talk about genetics. I'm not going to do a lot, but stress is linked to this kind of shortening of telomeres. And so that there may be not genetic difference, but ways that we look at our genomes and see some difference. Now, jumping over to my favorite question. We've been through this one before, right? 1918, we have historical reference, we go through plague. My guess is if we went back all the way through time, we'd see the same things. I love narrative. It's I think, becoming more prominent in discussions across fields. But when you look back at COVID, what do you think the narrative will be around health disparities? Will it be that the same thing happened again? Will it be a moment of momentum? Based on what you're seeing and what you know of history, what do you expect? I get to ask questions and then just sit back.
Oh man, that's actually a terrifying question, because I tend to be incredibly cynical, in part because of, the things that we've said over the course of this hour. Is like, we already know these things. It wasn't new information. It's new information to some folks, but it's not new to folks who have been working in these spaces. And so I'm worried that, at the next pandemic, whether it's in 20 years, which is likely because we, environmental encroachments, right? Or in 100 years, I'm worried that, a lot of folks will be having the same aha epiphanies that they ought to have had back in 2020, So, so that's the cynical part of me. The other part of me recognizes that, we were talking about, white supremacy and structural racism since we've had lungs and voices. And, this summer, a lot more people started talking about white supremacy and structural racism. And I will never forget the day when I went on Amazon and Amazon told me that Black Lives Matter, and they gave me some suggested readings. There is hope in this moment that, if we kind of, engage in the right movements and maybe talk to the right policymakers, that there can be something concrete that we realize from this moment. So sorry for taking up that.
No, we have a couple minutes left. I'd love to hear from Dr. Lamas and Dr. Perry.
I'll be quick. I just said we can still determine what that story is. And there's a lot we can't, nearly 180,000 people dead, more will die. We can't change that, but, and this sounds a little Pollyanna-ish, obviously, but there is still something that is true about it, which is that it's not in our power right here, but it's in the collective, everybody's sort of power to change what that outcome is. So I hope we don't waste it.
Dr. Perry?
I'll just say really quickly, I think just going back to what Kiara was saying earlier about structural racism and all of these issues that are tied to it, I think that, we know sort of cognitively, the further away we move from something, an event, right, the less urgency and stress we feel about it, especially if it's not directly tied to us and our in-group, right? And so I do think that the time is right, but I do think that we are in a specific circumstance right now socially where perhaps change can happen. But I think if we move too far away from it, then people might forget, right? And they might not have the same sense of urgency around change. And so it's a little bit of hope and a little bit of cynicalness.
Well, I think we need the cynical to force the work to be done, right?
That's right, yeah.
If I had one hope for this conversation, it's that people begin to understand and think about these complicated levels of interlocking structures, that the outcomes look pretty different for Dr. Perry and Dr. Bridges and myself and Dr. Lamas and women, right? And all these groups that you may not think about as out groups that are. And so to bear that in mind and to help let it guide your behavior or your training or the voice that you have. This is, again, the first in a series. I hope that maybe not in 20 years, but maybe in 6 months, perhaps we can revisit this and have another conversation, keeping our ears to the ground. But I, again, want to just thank our audience for their wonderful questions. I'm sorry we couldn't get to more, but I will endeavor to do that as we move forward through the series. So thank you again, panelists. A huge round of applause. From me, in case you can't hear all the other applause. And a thank you to the staff at Science Society, Sarah Rispin-Sedlak, Timothy McDermott, Andrew Perikak. Thank you so much for your work. Have a wonderful weekend, everyone.